The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines podcast series. My name is Shanna McKernan, and today I'm interviewing Dr. Brian Schneider, an author on management of immune-related adverse events in patients treated with immune checkpoint inhibitor therapy, American Society of Clinical Oncology Clinical Practice Guideline, written in collaboration with the National Comprehensive Cancer Network. Thank you for being here, Dr. Schneider.
Thank you. Appreciate you having me.
First of all, can you give us an overview of what this guideline generally covers?
So this guideline is really to help the clinicians manage immune-related adverse events from the immune checkpoint blockade therapies that we are currently using. So the guideline really focuses on side effects from the PD-1, PD-L1 inhibitors, and the CTLA-4 inhibitor ipilimumab. The guideline does not cover other immunotherapies like CAR T-cell therapies. And so this guideline really helps the clinician grade the toxicity or the side effect from the immunotherapy, and then offers potential treatment recommendations.
What are some of the more common immune-related adverse events?
So fortunately, with these agents, side effects are rare, and most of the patients would tell us that receiving the immunotherapy is actually easier than the chemotherapy that they have previously received. But unfortunately, there's no free lunch with these agents, and for the side effects that we see, and at least what I discuss with patients initially, there are common ones that they may run across, and typically it is inflammatory side effects to the skin, the endocrine glands, the GI tract, and the liver. And so the patients may develop a rash or develop pruritus. Very common to say that they may develop a significant itchy sensation. Loose stools are common. And then one that I discuss with other clinicians is elevation in amylase and lipase that are not symptomatic, but are very commonly seen when tested and rarely progress to clinically relevant pancreatitis, but it is a common side effect. And then there are the very rare but potentially life-threatening side effects when there is inflammatory reactions in the lung, the heart, the central nervous system, musculoskeletal system, and even hematologic toxicities that one must be aware of. And it really depends on the type of therapy. And so what we have seen is the anti-CTLA-4 therapies may have more severe side effects compared to the PD-1, PD-L1 therapies. As our melanoma colleagues have shown us, we do see more rash, more colitis, and more hypophysitis with anti-CTLA-4 treatment. And with the PD-1, PD-L1 inhibitors, we commonly see, I shouldn't say commonly, but we do see more pneumonitis and thyroiditis when compared to the anti-CTLA-4. And there is no question that the combination therapies also increase the risk of the immune-related adverse events. So as we are using combined or dual immune checkpoint inhibitor therapies with PD-1 and CTLA-4 antagonists, I think the risks of these side effects do increase fairly substantially.
And how do these immune-related adverse events differ from toxicity that may be associated with something like chemotherapy?
So when we think about the side effects of chemotherapy, we're really thinking about what happens when we damage cells that are dividing rapidly. So we commonly see alopecia, bone marrow suppression that can potentially lead to bleeding or life-threatening infections if their white blood cell count drops too low. Nausea and vomiting, obviously one of the side effects from chemotherapy that patients worry about, and rightfully so. But I think from a treating physician standpoint, there is a predictable timing to these side effects, and we know that there may be delayed nausea a few days after receiving the chemotherapy, and that the blood count nadir may occur 10 to 14 days after receiving the therapy. And so as we have used chemotherapy for decades, we've become comfortable kind of with the timing and management of these side effects. Immunotherapy is just an entirely different situation. When the toxicity is related to an overactive immune system, where basically the immune system is attacking the patient's own body, the timing is not as predictable, unfortunately. Although we do see the side effects if they occur usually within weeks to months of initiating these therapies. And we do see skin toxicity relatively early. It is not as predictable as we see with chemotherapy. And so there have been severe toxicities that can occur within days of the very first treatment. And we can see these side effects occur even several months after discontinuing the agents. And so that makes it more of a challenge for the practicing clinician to identify and manage these side effects.
And what are some of the key points or overarching principles to successful management of immune-related adverse events?
So I think the biggest problem we face is that these side effects masquerade as other common conditions we manage in oncology. And so it's always important to have side effects from the immunotherapy on the differential, because commonly, again, they will present as symptoms that we may attribute to other issues. So, for example, a patient presenting with profound fatigue, we may just, chalk up to the cancer or to previous therapies, when in reality it's hypothyroidism. A patient presenting with cough, shortness of breath, dyspnea on exertion, again, may be felt to be progression of the cancer, or the patient developed pneumonia when in reality it's immune-mediated pneumonitis. Patients may call complaining of diarrhea, but then backtrack and say, well, they may have eaten something funny the day before, when in reality it's immune-mediated colitis. So it's always important to be thinking about this as a potential etiology for their symptoms. I think it's important to identify these side effects early. Clearly, we want to rule out other causes of these symptoms, and oftentimes infection or cancer progression are equally likely as the cause of the patient's symptoms. But if there's truly concern that this is a side effect of the immunotherapy and the patient is in dire straits, it's certainly reasonable to start high-dose corticosteroid early while the workup is ongoing, because the sooner the patient is treated, the better chance of resolving it and averting potentially long-term morbidity. I think one of the other lessons that we've all kind of learned the hard way is that stopping the immunotherapy is not often enough, especially for our grade 2 and 3 toxicities. I think, again, as we've been comfortable with the management of chemotherapy, the first thing we do is stop the chemo and give them a break, and oftentimes that's all that's needed. But unfortunately, especially for the higher grades of immune-related side effects, the stopping of the agent is usually just half of the issue, and then starting some temporary immunosuppression with glucocorticoids is really required. And also that these glucocorticoids need to be continued for a prolonged period of time. I think that's another lesson that we learn the hard way. We're also accustomed to a quick burst and taper of steroid where we may give them a high dose for a week and then taper off. And more often than not, that's going to be inadequate in managing these immune-related adverse events. More often than not, the patients are going to need several weeks of high-dose steroid followed by a prolonged taper that can occur over a matter of months.
Is there a role for multidisciplinary care in immune-related adverse event management?
Definitely. As my mentor jokingly said to us once, we were trained to be oncologists, but with the development of all these new agents, we've had to branch out. And so when the VEGF pathway inhibitors came into practice, we had to relearn to be internists to manage sometimes very significant hypertension. And when the EGFR tyrosine kinase came into practice, we had to learn to be dermatologists and manage significant rash. Now, as you can see, with toxicities that span multiple disciplines, including gastroenterology, hepatology, pulmonary, endocrine, neurology, it's critical to get the subspecialists involved early to help with the management, because the oncologist may not be as familiar with use of other immunosuppressants that the subspecialists may have more experience with. So for example, infliximab is an anti-TNF antibody used by gastroenterologists for inflammatory bowel conditions like Crohn's disease or ulcerative colitis. And this agent has been used effectively to treat immune checkpoint inhibitor induced colitis that has failed to improve with high-dose steroid. And so the subspecialist involvement, may prevent the complications from long-term steroid use because we worry that oftentimes there can be significant morbidity and mortality from long-term steroid use, as the patients may succumb to opportunistic infections like pneumocystis pneumonia, aspergillus pneumonia, HSV sepsis, mucormycosis. So having early recognition of these significant side effects and getting the specialist involved may help get the toxicity under control in a quicker period of time and eliminate these other potential bad outcomes for these patients. Also, something that's not often discussed is early recognition from our emergency medicine colleagues is important, as they are, unfortunately going to be on the front line when facing some of these potentially life-threatening side effects. And so working closely with them so that they know what the warning signs and how to manage these side effects is going to be critical moving forward as these agents are used more and more in our oncology practices.
And finally, how will these guideline recommendations affect patients?
So early detection and treatment may prevent progressive toxicity that really can have substantial morbidity and even be lethal. And I think this may afford the patient a chance of potentially restarting the immunotherapy that may be, critical to controlling their cancer. And so I think as the word gets out about best practices in managing these potentially significant side effects, we can see our community colleagues, emergency room, and our subspecialists being able to more efficiently identify and treat these significant side effects that will hopefully not derail the patient's therapy from what's clearly a life-threatening malignancy.
Okay, thank you for your time today, Dr. Schneider, and thank you to all of our listeners for tuning into the ASCO Guidelines podcast series. If you've enjoyed what you've heard today, please rate and review the podcast and refer to the show to a colleague. Thank you.